This is QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.live 2024. In fact, January 27th and 28th. That's like 6 weeks away. Now's a good time to register, and be sure you register for your hotel because the rates go up after January 5. Today's case is what to do with the ANA positive consult. This is a no-brainer for most rheumatologists. If you're smart like me and many others, you've got a template so that when this consult comes in, you fill in 3 or 4 blanks: the age, the background medical history, the medicines they're taking. The story reads the same, sent to you by the primary care because the ANA was positive. The ANA was drawn because of X, Y, and Z reasons. There's no ample evidence of lupus, does not meet criteria for lupus. No reason to worry. ANA positivity is common. Thank you very much for this consult. But the real question is, how many of those ANA positive consults really do have real underlying autoimmune disease? Well, the numbers should make you pause and worry. While the Lupus Foundation and others that are in the lupus look at me business will tell you there's 5 million people with lupus or some crazy number, the real epidemiologic facts are that there's somewhere between 240 and 280,000 people in the United States who have SLE. That the proportion of those who have really bad SLE is probably 10% that might need brand new therapies. I've always quoted that, since ANAs are done and devised with a 5% false positive rate in normal controls, that means 5% of the population, healthy population, should have a positive ANA. Given your population where you live, you should be able to figure out how many. Where I live, that's about 38 million people with a positive ANA. That's very different than the 239,000 who actually have lupus. So, the numbers are staggeringly in favor of your ANA positive consult going absolutely nowhere. But the patient who gets referred to the rheumatologist, it's enriched for the potential for disease. I was working once with a bunch of great researchers, Virginia Pasquale and other people at the Baylor Research Institute, and we were doing microarrays on lupus and Still's disease and whatnot, looking at the RNA expression profiles of disease states and coming up with some interesting data. And as a control, I would provide a number of ANA positive fibromyalgia patients or ANA positive who didn't have lupus patients. And when those were run and compared to people with lupus and other autoimmune diseases, 5%, sometimes a little bit more, of those people had the exact same gene expression profile as someone who had clear-cut lupus, which led me to believe that, there's some people in here, 1 out of 20, maybe 1 out of 10, who will, in fact, progress to autoimmune disease, if not lupus. The actual numbers on autoimmune disease in the population is about 8%. 1 in 12 women, 1 in 20 males. These are 2005 numbers, and that means that there's at least 23.5 million with autoimmune disease. That's pretty close to my 38 million who have a positive ANA. So the question is, what do you do with this patient? 35 years old, sent by the primary care, has a positive ANA. He did the ANA because the patient has arthralgias, or because they complain of fever, or because of whatever. And the question is, do you say, pat him on the back, say, you're fine, call me when you get these 3 lupus symptoms, and you give them some guidance? I think the point is that not all ANA positive consults should be sent out into the world never to come back. I think that you need to reappoint some of these patients, maybe as much as 10%, so that you'll pick up at least half of those that will have real disease. Who do you reappoint? It's going to be people who have more specific symptoms for lupus, not arthralgia, right? Not feeling bad, not fatigue. But if they're losing hair and have patches of alopecia, or there's hair on the pillow in the morning, that's specific. If they had a clear-cut documented episode of serositis that was unexplained, if they have cytopenias that are not clear on what the etiology of that is, I would bring that patient back in 3 or 6 months and sort of do another clinical check. Not necessarily do another ANA. That's not going to make me any more helpful. I'm not more likely to bring them back if they have 1 in 25/60 compared to 1 in 160. I don't think that the strength of the titer is as predictive as we would like it to be. I think the pattern is more predictive, with homogeneous and speckled being poorly predictive, and the other ones, nuclear and centromeric, and certainly a rim pattern, which you don't see very much of anymore, being much more specific. I think you have to think who you're going to bring back. You know, this topic is going to be discussed at RheumNow.live by Dr. David Karp, Chief of Rheumatology at UT Southwestern, where I heard him give a fabulous lecture on preclinical disease, using lupus as an example, and using different set of nomenclature as to how we should consider these patients. And he has great data about how these people could have disease, and what are the studies that show who we might treat, who we might watch more closely, who's going to evolve into lupus in the future. This is going to be covered by Dr. Karp on our Saturday 27th, 4 o'clock or so, end of day session on lupus. Be there and enjoy this lecture at RheumNow Live.